The cause of death was listed as a fatal reaction to a standard therapeutic dose of medication. The medical examiner disagreed, citing an unexpected inconsistency in the toxicological findings that suggested the dose had been appropriate given conventional pharmacokinetic models. The evidence was consistent with negligence by the prescribing physician due to an oversight in patient care. It was also consistent with another explanation: CYP2D6 deficiency, a genetic condition rendering the deceased a poor metabolizer of certain drugs. This revelation underscored that the therapeutic dose administered was clinically correct but dangerously inappropriate for the individual's unique genetic profile, highlighting the complex interplay between pharmacogenomics and patient safety. Chapter: Case Background. The incident under scrutiny transpired in a metropolitan hospital on March 15, during routine administration of antidepressants to an adult patient by a licensed physician. The case was initially reported by nursing staff, who observed uncharacteristic symptoms, such as severe agitation and bradycardia, shortly after medication ingestion. Initially, the attending medical team assumed these reactions were due to side effects from drug interactions or improper dosage. However, when the deceased's condition rapidly deteriorated despite immediate intervention, suspicion of a more profound underlying cause arose. The hospital administration was notified, initiating an internal review and forensic investigation into the circumstances surrounding the patient's untimely demise. The medical examiner's office was subsequently engaged to conduct a thorough autopsy and toxicological analysis. Chapter: Initial findings upon arrival at the residence. First responders noted a scene consistent with an acute medical emergency. The deceased was found supine on the living room floor, unresponsive and cyanotic. No external signs of trauma were observed, ruling out mechanical or blunt force injuries as the cause of death. Witnesses reported that the deceased had ingested medication prescribed by their physician earlier in the day, without prior adverse reactions. Initial vital sign assessments revealed respiratory distress and bradycardia indicative of a severe systemic reaction. The deceased's medical history was reviewed, revealing no previous incidents related to drug consumption or documented allergies. The manner of death was initially classified as undetermined due to the unexpected nature of the event in an otherwise healthy individual with no prior issues on medication. This prompted further toxicological and pharmacogenomic analysis to elucidate potential underlying factors contributing to the fatal reaction. Chapter: Forensic investigation. At the scene, blood samples were collected from the deceased alongside urine specimens for toxicological analysis. Hair follicles provided genetic material necessary for pharmacogenomic testing. Medication containers and packaging, including dosing information, were meticulously documented and sealed. A medical chart detailing prescribed medication was secured with a focus on CYP2D6 inhibitor drugs. Notably absent was any indication of overdose or misuse. The therapeutic dose was consistent with standard protocol. The chain of custody logs maintained integrity throughout evidence handling and analysis, ensuring no contamination or tampering. The presence of metabolites in blood samples corroborated drug administration as directed by the physician, aligning with pharmacogenomic findings. The laboratory analysis included comprehensive pharmacogenomic testing to assess the genetic profile of the deceased regarding drug metabolism enzymes. Specifically, the CYP2D6 gene was sequenced and genotyped for known polymorphisms affecting enzyme activity. The results revealed a homozygous duplication of the non-functional CYP2D6*5 allele, confirming the status as a poor metabolizer with severely reduced CYP2D6 enzyme function. Toxicological analysis confirmed therapeutic levels of the prescribed medication in blood and urine samples, establishing that the administered dose was within clinical guidelines for most individuals. Tissue samples from multiple organs showed no signs of acute intoxication or overdose, but displayed histopathologic evidence consistent with drug-induced toxicity due to prolonged exposure at steady-state concentrations typical of a poor metabolizer. Profile. Toxicological analysis confirmed therapeutic levels of the prescribed medication in blood and urine samples, establishing that the administered dose was within clinical guidelines for most individuals. Microscopic examination revealed hepatocellular damage, indicative of cumulative drug effects over time. These findings collectively demonstrated that the patient's unique genetic predisposition was responsible for the fatal outcome rather than medical negligence or inappropriate dosing. Forensic analysis commenced with a meticulous review of medical records and prescription history to establish the deceased's medication regimen and dosing schedule. Subsequent genetic testing revealed CYP2D6 enzyme deficiency, confirming the patient was a poor metabolizer. This finding corroborated the doctor's assertion that the prescribed dose adhered to standard therapeutic guidelines for non-deficient individuals. Radiocarbon dating of soft tissues from the body provided an estimated postmortem interval of 48 hours, aligning with medical records indicating time of last contact and administration of medication. The timeline confirmed that the toxic reaction was due to the deceased's unique genetic profile rather than excessive dosing or negligence by the healthcare provider. This evidence substantiated the doctor's alibi and highlighted the critical role of pharmacogenomics in clinical practice, thereby challenging preconceived notions of medical malpractice based on fundamental attribution error. The forensic analysis revealed a CYP2D6 enzyme deficiency in the deceased's genetic makeup, indicating poor metabolism of certain drugs. This finding substantiated that the prescribed therapeutic dose was medically appropriate and not causative of negligence on part of the physician. Expert testimony would affirm that pharmacogenomic testing conclusively identified the underlying cause of the toxic reaction as an inherent inability to process the medication at a normal rate. The evidence clearly delineates between clinical appropriateness and genetic predisposition, thereby exonerating the medical practitioner from accusations of malpractice. In court, an expert witness would assert under oath that the physician's actions were in accordance with established medical protocols, highlighting the critical role of pharmacogenomics in personalized medicine to prevent such incidents in future cases. The evidence clearly delineates between clinical appropriateness and genetic predisposition, thereby exonerating the medical practitioner from accusations of malpractice. Chapter: Resolution. The case of the deceased patient who suffered a fatal toxic reaction to a standard therapeutic dose has been thoroughly examined through the lens of pharmacogenomics. Initial assessments pointed towards medical negligence on the part of the treating physician, with accusations of inappropriate dosing and lack of due diligence in monitoring adverse effects. However, advanced genetic testing revealed that the deceased was a poor metabolizer due to a CYP2D6 enzyme deficiency. This specific genotype results in significantly reduced metabolism of certain drugs, leading to elevated serum levels even when administered at standard therapeutic doses. The forensic analysis confirmed that the prescribed dosage was clinically appropriate for most individuals, but toxic for those with this genetic variant. The fundamental attribution error played a significant role in misdirecting initial investigations towards professional misconduct, rather than recognizing the underlying genetic predisposition of the deceased. This case underscores the critical importance of pharmacogenomic profiling to tailor treatment regimens and prevent such tragic outcomes, shifting medical practice towards personalized medicine approaches that account for individual genetic variability. The fundamental attribution error played a significant role in misdirecting initial investigations towards professional misconduct, rather than recognizing the underlying genetic predisposition of the deceased. This case underscores the critical role of pharmacogenomic testing in medical practice, highlighting the necessity for individualized treatment based on genetic profiles. It illustrates how fundamental attribution error can mislead investigations, emphasizing the need for comprehensive forensic analysis to account for all potential variables. The file remains open,